Today we're going to be talking about getting off to a good start, hospital practices that encourage good breastfeeding. And it's not all about the latch. Welcome to Sounds Healthy, a podcast of University Health System. I'm your host, Elizabeth Allen. We're here today with Kate McLachlan. She's an RN and certified lactation consultant with University Health System, and she works with new moms all the time. How are you doing today, Kate?
I'm doing great. Thanks, Elizabeth.
Thanks for joining us. So in the hospital, you see new moms. What are some of the things that we're doing and the hospitals can do to make breastfeeding easier, more successful, that aren't breastfeeding itself?
Right. So there are so many ways that we can set up the mother-baby dyad to have success with breastfeeding that have nothing to do, as you said at the top, with latching or actual direct breastfeeding at all. So one of those things is putting babies on their moms as soon as they come out. So we call this skin-to-skin contact. In the NICUs, we call it the kangaroo care model. And so the notion behind this is that we are mammals, and we try to imagine what would happen if we were giving birth and nobody was watching and nobody was messing with the process. So the biologic norm for mammals is that babies are born, the mother cleans them off, licks them down, and they find their way to the breast. So likewise with humans, at birth, what we've learned is that if we mess with the process as little as possible, and we put the babies immediately skin to skin with mom, that there are great benefits for this transition of the baby to extrauterine life.
That sounds really messy and very different from most hospital practices.
So there's a little bit of mess involved, and it's true that we have to get our heads around allowing there to be a little bit more mess in the process. But we do wipe off the baby, and we wipe off the mom, because it is important that the baby stay warm. And so just with a quick wipe down of the baby and the mom, the baby can then go skin to skin with mom. And if we leave them there, babies are hardwired to go through a sequence of sort of unfolding processes. And if we allow these unfolding processes to occur, what typically happens is that moms look at their baby, they touch their baby fingertips first, then with full hands, and then they envelop them and bring them up. And the baby opens their eyes and begins to explore the environment and then makes its way to the food source. And so we allow this process to unfold naturally. What typically happens is babies find their way to the food source, and with a little bit of assistance in getting them in the right neighborhood, they are able to latch naturally.
That sounds really beautiful. Like flowers blossoming, sun coming up, birds singing.
It is beautiful. It is. It's amazing what happens when we sort of learn to keep a little bit more hands off. Now, of course, when I say this, we're at University Hospital, which is a high acuity hospital. So we're looking at moms who do have some risks usually in terms of their pregnancies. So as long as everything is going well, the thing is, what we've learned is that we can sort of see that, and we don't necessarily need to intervene like we once did, right? So at University Hospital, it's our protocol now to delay the clamping of the cord, for instance. So the baby is born and put on mom, and as long as the baby looks okay, we let the baby adjust. And we keep the cord intact for 60 seconds before we clamp it. And what this does is it perfuses the baby with the blood from the cord, which is at mom's body temperature. And so this cold stress that we're so concerned about with the baby coming out into the hospital environment, which I don't know if you've been in a hospital recently, but they are very cold. And so getting this perfusion of mother body temperature blood really helps the baby with their temperature. It also provides all of the nutrients and oxygen and good stuff that's in that blood.
While they're still making that adjustment to opening their lungs to air.
Exactly.
It's kind of a transition period.
Right.
You don't just flip on the lights.
That's right. It's a process. And when we allow that process to unfold and we delay that clamping of the cord, and we kind of try to stay hands off. It's one of the hardest things for nurses and physicians and midwives to do. But what we watch happen is we watch the baby make its way to the breast. And then, because mom is in this very high oxytocin state, which is the hormone of labor, and the baby is in this very sensitive, all of their senses are coming on board. And so mom and baby are in this perfect state for baby to latch, and mom actually releases her colostrum, which is the early milk. And there are researchers at Stanford Newborn Nursery. Dr. Jane Morton has done research about this first hour after delivery and baby achieving a good latch, and the significance that it creates a milk supply issue 6 and 8 weeks out postpartum. So moms have more milk 6 and 8 weeks out postpartum if their baby gets this good first latch. So the mom is in this high oxytocin state, and the baby is exploring all of its senses. And the mom subsequently creates a robust supply of colostrum. The baby takes in a good amount of food, and this all happens in this first 1 to 2 hours. After the 1 to 2 hour window closes, then baby takes what we call their birthday nap, which is that all of the overwhelm of experiencing labor and experiencing delivery and adjustment to extrauterine life all sort of catches up with them, and they sleep. And they sleep hard.
And
it can
if
be hard
they
to wake
only
them up.
knew, if they only knew what was ahead of them.
That's right. So we tell parents, take advantage of this birthday nap and get some rest yourselves, because of course everybody is exhausted in this picture. But if they've gotten that good first latch, then they are able to sustain themselves through the birthday nap with their colostrum on board. So in this, so we're talking about skin to skin and putting baby skin to skin immediately and delaying the cord clamping. And so probably people are wondering about what happens after C-sections, because in the OR, it's actually even colder than in the other delivery rooms.
And I was going to just say, I had a C-section. It was nothing like that. I feel like I missed out on so much.
So we know what to do about that too, which is that it doesn't make good logistical sense for us, or it's not particularly safe in our ORs, given the size and the table that mom is on, to really be able to put babies skin to skin. However, we bring baby up to say hi to mom. Then baby is taken to the nursery. But as soon as mom is coming out of the OR and going to the recovery room, that's when we reunite baby with mom. And baby is still in this wide open 1 to 2 hour window of showing their hunger cues and eating their hands and licking their lips and making their cute baby faces. And we put the baby skin to skin with mom at that time. And again, we leave them there to make their adjustment, to make their journey to the breast, get a little bit of assistance, and then we leave baby skin to skin throughout that whole first feed.
You had mentioned when we were kind of talking earlier about a researcher named Bergman, I think?
Yeah, there's the grandfather of skin-to-skin and kangaroo care, Dr. Niels Bergman, is a Swedish physician who calls himself a public health physician, but he is also a perinatal neuroscientist, neurophysiologist maybe. And he was one of the founders of the kangaroo mother care movement. And so he's done amazing years and years of research on the benefits of skin-to-skin. And so we're talking in this context of breastfeeding about the benefits being that baby gets to the breast and gets that good first colostrum. But Dr. Bergman really emphasizes the importance of skin-to-skin throughout the whole postnatal period, months, the first months of baby's life, that the more time baby spends skin-to-skin, it helps them with their neurologic development as well. But even in that first time that baby goes skin to skin, there are other physiologic benefits besides just the getting off the breastfeeding to a good start. And that is that babies maintain, and this is part of the kangaroo mother care movement for premature babies, when we used to put babies in incubators, which we still do, and there are times when that needs to happen. But what we also discovered was that when babies are skin to skin with their moms, all of their vital signs regulate. So their heartbeat and their respirations come into the normal range, and they regulate their temperature better when they're skin to skin with their mom. So the mom is like a radiant heater. The baby connects, of course, with that heartbeat and that breathing that they've known their whole lives. And So what it does for our moms who maybe are at risk for, or babies that are at risk for hypoglycemia, for instance, if they have a mom with gestational diabetes. We have high diabetes rates here in South Texas. If we have a mom who's a diabetic or a gestational diabetic, her baby's at a higher risk for maybe experiencing hypoglycemia. One of the things that can cause blood sugar to drop in babies is cold stress. So when we put the baby skin to skin, they regulate their temperature, and then they're less likely to have fluctuations in their blood glucose as a result.
Yeah, and aren't we measuring their cortisol levels? We're doing some really cool research on what seems like one of those sort of natural no-brainers, mother's love,
Right.
is actually good for you, but we're actually measuring that now.
Right. So cortisol levels are the baby's stress levels. And that's another benefit of skin to skin, both for baby and for mom. So in studies that have been done measuring baby's cortisol levels and measuring mom's cortisol levels, we find that both are decreased. So that's a plus, a win-win for babies and moms to have lower levels of stress.
Until they become teenagers.
Well, right.
But that's a different story. Can you help me with that?
No, ma'am. Out of my wheelhouse.
Speaking of teenagers, let's talk about delayed bathing.
It's true. My 13-year-old never wants to bathe. So delayed bathing. So we talked about how skin to skin helps regulate baby's temperature. Babies have come from a neutral thermal environment, right? The inside of mom is at a pretty constant temperature. They come from a water environment that's a constant temperature out into the cold hospital room. They go skin to skin with mom. It helps them regulate that body temperature. So it used to be practice in most hospitals to, partly because of what you reference in terms of how perhaps unpleasant it might be to have the amniotic fluid and the vernix, the white cheesy stuff that's on the baby. Maybe there's a little bit of blood, maybe there's a little bit of poop, who knows. But we wipe all that off, but it's still really good to keep some of that stuff on the baby. And we've learned that there's reasons for that partly have to do with temperature, but partly have to do with some other things. So it used to be hospital practice to bathe babies right away. And what we've learned is that when we bathe the baby, it makes them cold because we're bathing them in an open crib, typically in the nursery. And so they get cold and they cry and their cortisol levels go up because they're stressed during the bath. So when we delay that bath until they're a little bit better at regulating their temperature, it really helps. So I'll go into it a little bit later how we do that. But in the immediate, keeping the vernix and the amniotic fluid and the bacteria from mom on the baby is actually very beneficial for baby's immune system as well. So the bacteria from mom and from baby, when baby puts their hand to their mouth and they lick and they get all of that birth juice and stuff, it actually helps develop their microbiome. So the bacteria that colonizes their gut, that helps develop their immune system, they partly get from putting their hands in their mouths and being on mom right after the delivery. So that's a plus. That white cheesy vernix that's on the babies, especially if they're a little bit early, there tends to be a little bit more of it. It's a moisture barrier because babies are living in water. So it makes them not get all, pruned up like when you've been in the bathtub for too long. And that moisture barrier is actually still beneficial even in the external world because baby's skin is very sensitive. So what we've learned is that leaving that vernix and that moisture barrier in place is a helpful protective for their skin. So at University Hospital, it's now our practice to delay the bath until at least 8 hours postpartum because then the baby's temperature is stable enough that we can do the bath at the bedside in the mom's room. So that's a real plus because parents, of course, love to be involved in the baby's first bath. And the way we do the bath is we use an immersion tub. So we bring in a tub and we fill it with warm water, and we actually immerse the baby in the water as opposed to the open crib sponge bathing. So this type of immersion bath keeps baby warm. And in fact, it's really wonderful to watch. We've got some good video of it. And there was a physician in the 70s, I think a French physician named Leboyer, and they used to do the Leboyer bath at the bedside after delivery. So it was sort of a hippie French thing in the 70s. But what was so beautiful about it, and there were beautiful books of photographs of this, is that when babies go back into the water, it's their natural environment. It's what they're used to. So when you put them in the bath, they open up and unfold and typically thoroughly enjoy the experience. So when we bathe the babies like that, there's less stress. They maintain their body temperature. We put them, the parents get to be involved, and then we put them directly on mom, skin to skin afterwards, and then usually breastfeeding ensues.
So they're like, I'm back.
Exactly.
Wait. Oh, okay, I guess I'll eat now.
That's right.
So all this means that that mom and baby are spending a lot of time very close together.
That's exactly right. All of these hospital practices that we're talking about are designed to minimize separation of mother and baby. So the bath happens at the bedside. All of our routine procedures happen at the bedside instead of in a newborn nursery. And we call this rooming in, which is that when mom has the baby really should never leave her sight until she leaves, unless there's an operative procedure such as a circumcision, which does not happen at the bedside. But all other routine procedures should happen right there at the bedside, which again it involves parents in the care. I think a lot of parents are worry about what's happening to their baby when it's in the nursery and they can't see it. And so this way they get to be a part of the whole process, and it keeps baby more calm. It keeps the parents more calm to have everything done at the bedside. It also really benefits breastfeeding because we're not separating them. So parents are learning babies' feeding cues and feeding on cue, which is what we recommend for breastfeeding, which means we watch for when baby is hungry, because breastfed babies don't typically feed on a clock. They tend to cluster their feeds together, typically at night, because that's when they're more awake and alert, because that's the baby's natural circadian rhythms. So having the parents be able to watch the baby for cues as opposed to having the baby brought to them on a schedule really enhances the breastfeeding, because the more the baby breastfeeds in the first couple of days, they're basically putting their order in for a full milk supply. The more baby breastfeeds, the quicker the milk comes in, the more robust the milk supply. So that's why we promote rooming in.
Then you go home and the baby starts to nurse and it feels like 1,000 needles are shooting out of your nipples all at once.
It can happen. It can happen. So we prepare moms. So that's another job of the bedside nurses and the lactation team at the hospital, is to give new parents lots of information for after discharge. Sometimes it's a little overwhelming, but this is always a question that breastfeeding moms have is, well, what's going to happen over the next few days?
It's going to be, you're going to wake up.
Yeah. So we talk about engorgement. So I think what you're getting at is that waking up maybe on night 3, maybe day 4, with a very full breasts. And it's very surprising to women who haven't done this before, or even ones who have and have forgotten what engorgement is all about. And so when the milk first comes in, I always talk about how it's like the faucets get turned on full blast. And it's not just milk. There's a process going on called engorgement, which is an inflammatory process. So suddenly all of these lobules, all that are like sacks of grapes that extend into the breast tissue all the way around the breast, they start to fill with milk. But the fullness and tightness and discomfort that you're describing in the breast is really the inflammatory process of the tissue around all of those lobules. So suddenly there's this new tightness that the breasts aren't used to. And so the inflammatory response makes all of the tissue swell, which makes moms who feel like, well, now I'm full, baby's going to get on and just be gulping down milk at the breast. And then when that doesn't happen, or they put the pump on, and that doesn't happen, that the milk just flows out, they wonder why and if something wrong. And maybe it's even so sore and uncomfortable that they don't latch their baby or they don't pump. And that's actually the worst thing that you can do. So what we need to do is control the inflammatory process. So just like how you'd control the inflammatory process in other parts of your body, for instance, if you sprain your ankle and your ankle starts to swell, you're going to put cold on it because cold actually reduces swelling. So we encourage moms to get that bag of frozen peas out of the freezer and put cold to the breasts to reduce the inflammation. There's also something called lymphatic massage, where we need to move that fluid that's in the tissue back into the lymphatic system of the body, which is in the lymph nodes or in the armpit and in the neck. And so if a mom lays flat on her back and gently massages from nipple to armpit, nipple to neck, and moves the fluid out of the tissue, it will really reduce that swelling and that discomfort. So between the cold and the massage and taking your ibuprofen, you will manage the discomfort. But then the next most important message is to continue breastfeeding baby at least 8 times every 24 hours. So you're still going to respond to those hunger cues and you're still going to breastfeed your baby frequently.
So I've just got a brilliant new idea for baby shower gifts, like a case of individual bags of frozen peas.
Love it.
So massaging, wouldn't that hurt?
Yeah. So how mom massages is really important. It's important to remember that the breast is a gland and not a muscle. And so we want to massage the breast gently. So that's what people say is that, oh, my lactation consultant or a nurse or someone showed me to, really massage hard. And that is not the best way. That's going to increase the inflammatory process.
That sounds very discouraging.
Yes, we want ibuprofen and cold to hopefully deal with the immediate discomfort, and then gentle lymphatic massage. So just enough pressure to move the skin. And it's the consistency and duration of the massage, not the depth of the massage. So we really don't want people doing anything that's going to actually hurt.
This is not deep tissue folds.
That's right. This is gentle lymphatic massage.
And away from the nipple, just like
away from the nipple.
You're moving the fluids back
into the body.
Oh.
Exactly. And then, there is a difference between just what's the normal physiologic process of engorgement versus a condition that some people might have heard of called mastitis. And mastitis is an actual infection of the breast. If the milk stays in one place for too long, so say mom has a clogged duct, which is, there are these little ducts all throughout the ductal system that brings the milk out of the breast. And if milk gets lodged somewhere in there, you can feel it when you're doing this gentle lymphatic massage. You may feel some little nodules, some little round, firm areas in the breast. And it's important to massage those out because that can be a clogged duct. And if milk stays in one place for too long, it can begin to grow bacteria. Or if mom's baby hasn't had a good latch and there's been some damage to the nipple, so say the skin is open, that's now a portal for bacteria potentially. And if a mom has mastitis, we don't just want her to manage that the way that I'm talking about managing engorgement. So the difference is that what mom will usually experience is a reddened area. Usually it's kind of a wedge-shaped area of the breast that becomes red or very warm to the touch. And then typically what happens is mom begins to have a systemic reaction to this infection.
She starts to feel really bad.
Yeah, like she's been hit by a truck or has the flu. And so if you experience any of those things, the redness, the general body aches and flu-like symptoms, then it's really important to come in to your providers or to, here at University Hospital, we have a GYN emergency room that moms can come up to get antibiotics, to get it diagnosed and to get antibiotics, because the antibiotic course will help it very quickly. And to continue to breastfeed through all of this, because the infection isn't bad for baby. The baby doesn't get the infection from breastfeeding.
Okay, so you're not poisoning your baby.
Exactly, and the medications, the antibiotics are also safe with breastfeeding. The breast has a really effective filter, and so we really want moms to be sure to continue breastfeeding through this because that's the most important way to protect their milk supply and to be able to continue breastfeeding their baby.
So the baby's helping the mother.
Exactly.
Oh, that's awesome. Well, thank you very much for talking with us about this fascinating topic, and we will put some links on our site related to it.
Great. Thank you for having me.
You've been listening to Sounds Healthy, a production of University Health System in San Antonio, Texas. Produced and directed by me, Elizabeth Allen. Editing and audio production by Mark Greenberg. Web and digital support by Selena Mejia and Joe Campa. Executive producer Lenny Kirkman. If you like what you're hearing, be sure to subscribe on your favorite podcast channel. Yay!